Okay, so I guess we're going to start by introducing ourselves. I guess I can go first. My name is Arturo Chavez. I am the Director of Partnerships, Strategic Partnerships and Membership for LCAC 19. I have been an educator for 15 years in inner city high schools and have recently gone back to the original plan, which is to become a physician. So I teamed up with my friend from undergrad, which is Dr. Turner Veras, to help him out with this endeavor. And we are delighted today to be hosting a wonderful talk by Dr. Bustamante. And we're gonna have this session recorded, so for you guys to review later on. And then I'll pass it over to Angelica.
Hello everyone, bienvenidos y bienvenidas. Mi nombre es Angelica, and I currently work at Harbor UCLA as a research evaluator. And without further ado, Arturo Chavez, do you want to go ahead and introduce the doctor?
Sure. So Danny is away at a conference. He was in the middle of a flight, so he couldn't join us today, but I'm going to go ahead and introduce Dr. Bustamante. Arturo Vargas Bustamante is an associate professor at the UCLA Fielding School of Public Health Department of Health Policy and Management. He has a broad background in health policy with specific training and expertise in healthcare survey research and data analysis, healthcare cost estimation, economic valuation, and program evaluation. His research investigates unexplored or underexplored topics on access to healthcare, predominantly among Latinos, Hispanics, and immigrants in the US. He also specializes in the comparative analyses of healthcare delivery systems in Latin American countries. The outcomes of his research have had direct policy applications, particularly since they estimate the share of disparities that can be attributed to socioeconomic and demographic factors, and the corresponding part associated to health system variables, such as usual source of care and insurance status. Dr. Vargas Bustamante currently studies how healthcare providers in Mexican border cities, I'm from San Isidro, by the way, have adapted to the changing demand from US cross-border patients since the Affordable Care Act implementation. Dr. Vargas Bustamante earned his PhD and Master's in Public Policy and an MA in Economics from UC Berkeley. He earned his undergraduate degrees in politics and public administration from El Colegio de Mexico in Mexico City. So please join me in welcoming Dr. Vargas Bustamante. Dr. Bustamante, adelante.
Gracias. Thank you very much for joining us today. And well, just an update in my CV, I have been promoted to full professor, so I'm not an associate professor anymore. And I'm also the faculty research director of the recently endowed UCLA Latino Policy and Politics Institute. And at this organization called LPPI, we produce research that is policy relevant from the UCLA faculty and policy analysts. So today's presentation is going to be mostly from some of the research that we have produced in at LPPI. So can I share my screen?
Yeah, let me.
Okay, let me. Yeah, it seems that I can. Let me. Oh, yeah, this is it. Okay, so today's talk is going to be very informal. It's going to be more like I'm going to introduce you with some very basic updates on infections, deaths, hospitalizations from COVID-19 and how unequal it has been in terms of race and ethnic composition of California population. And also, I'm going to provide you with some updates about the rates of by race ethnicity of COVID-19 vaccinations. And after that, I'm going to go into summarizing some of this research that we have produced at LPPI, exploring why the Latinos in California have been disproportionately affected by COVID-19. And I will conclude with some policy solutions to address the current disparities that I'm going to be showing you. So let me see. Oh, yes. So first, I want to acknowledge that the latest figures are from March 21st, just a few days ago, that in California, approximately 8.5 million individuals have been diagnosed with COVID-19, and almost 87,485 individuals have died from the virus. We have already probably heard in the media and different forums that the impact of the pandemic has been disproportionate, primarily among Latinos and people of color. And I think that this slide summarizes very well these disparities. I think that an easy way to understand this graph is if you can see in the case of Latinos, Latinos are approximately 38% of the state's population. This is like the dark blue line. And the percentage of confirmed cases, it's almost 47.7%. This means that the share of cases exceeds the share of Latinos as the state's population. And you can see the same data for different race and ethnic groups in California. And in the case of the non-Latino white population, you can see that the share of non-Latino whites is similar to that of the Latino population, is about 36%. However, the percentage of confirmed cases, it's only 24.3%. So we see something similar in the case of individuals who have died from the virus. And you can see also as well here, Latinos are almost 44% of recorded deaths. This exceeds the share of Latinos from the state's population. And in the case of the non-Latino white population, is closer to the share of like the non-Latino white population in the state. However, it's still lower at 34.1%. These are numbers that essentially are representing what I showed you in the previous slide. And you can see that here, at least in the number of cases among the Latino population almost doubles those of the non-Latino white population. Here is the percentage of cases is almost 47.8%. And here, the percentage of California's population of the Latino population is 38.9%. But in the case of the non-Latino white, it's 36.6%.
Sorry, I'm
Sure.
just gonna stop you for 1 second because folks are saying they can't see the slide.
Oh,
I
okay.
can see the slide, but
Yeah.
I just want to make sure that others can as well. So.
Can everyone
Okay.
see?
Can everyone see the slides now? Yes?
Yes, okay. So would
Okay.
it be helpful to go back to the previous slide?
Yes,
please.
if you don't mind.
Yes,
Yeah.
okay.
Sorry
Well, this
about
is
that.
okay.
This
No
slide is really
worries.
important. Yeah, this
I
slide is
know
really
it's
important.
very important. So that's why I think it's crucial for me to show it again. So here you can see the latest figures by like a few days ago of confirmed cases by race ethnicity in the state and of reported deaths from COVID-19 by race ethnicity in California. And it's distributed by different, by the major race and ethnic groups in the state. And here the percentage of confirmed cases is the light blue, and the percentage of the state population is the dark blue. So here you can see that in the case of the Latino population, the light blue bar exceeds the percentage of the state population. The percentage of the state population by Latinos is approximately 38%. However, they reported almost 47.7% of cases. By contrast, in the non-Latino white population, that is kind of similar. The proportion of the state's population is about 36%. However, they only reported 24.3% of cases in California. And something similar happens in the case of deaths. As you can see here, that in the case of Latinos, it exceeds the share of the Latino population in the state, because that is 38% again. But of the overall deaths of COVID-19, 44% of those deaths have been among Latinos. In the case of the white population, the number of deaths, the share of deaths also increases to 34.1%, but is still below the share of the non-Latino white population as percentage of the state population. And you can see here for more clarity, this is the overall number of the figures that I showed you in the previous slide. You can see here in the case of the number of cases, the number of cases among Latinos is almost double those of the non-Latino white population. In case of the cases, again, is the same 47.8%, but in the case of the white population is 24.3%. While in the case of the number of deaths, is 37,462 deaths among Latinos. By contrast with the case of the non-Latino white population is 29,000 deaths. And this is the percentage deaths. And to compare and contrast, you can here have like the percentage of the California population that is 39.9% in the case of Latinos and 36.6% in the case of the non-Latino white population. And you can see that in other race and ethnic groups, in the case of the percentage deaths compared to the percentage of the California population, it exceeds in the case of the Latino population, in the case of the African American population, and in the case of the Native Hawaiian and other Pacific Islander population. These are the three race and ethnic groups in California that have been disproportionately affected by COVID-19 deaths. So this is another figure that it probably could help you conceptualize much better, that is proportionate impact of COVID-19 among Latinos. For those of you who understand how the death rate is calculated, in the case of the Latino populations, the death rate in California is 15% higher than statewide. And the way that the death rate is estimated is the overall number of deaths divided by the total of the specific population, in this case, the Latino population, and multiplied by 100,000 people. Here, for every 100,000 deaths in California, 239 are Latino and 208 are of all other ethnicities. So I think that this figure represents very clearly the disproportionate impact of COVID-19 among Latinos in the state. So what about vaccines? I think that's another metric where we can see the inequities in healthcare services delivered to different race and ethnic groups in the state. And in this case, you can see that there's this graph is very similar to the previous one, in the sense that the light blue color is the percentage of vaccines administered, at least one dose per race and ethnic group, and the dark blue is the percentage of vaccines of the vaccine eligible population. We know that different race and ethnic groups have different age profiles. So in this case, it's a good indicator that you have the percentage of vaccine eligible population, because the older the population is, more people are going to be eligible for that vaccine. And you can see that in the case of the Latino population, almost 31.2% of vaccine of individuals that have one dose are Latino. However, it's substantially lower to the threshold of the percentage of vaccine eligibility population. And in this case, it's also similar in the case of the white population, where the percentage of the eligible population is above the percentage of vaccines administered, but still it's closer to the percentage of vaccine eligible population. In this case as well, like the Black population is very close to percentage of vaccines administered to percentage of vaccines eligible. And the only race and ethnic group where where the vaccination rate exceeds the percentage of vaccines eligible population is in the case of Asian Americans in California. So what about the national figures? We know that California is a majority Latino state, but what about Latinos at the national scale? Well, the CDC in October of 2021 estimated the risk of COVID-19 infection, hospitalization, and death by race ethnicity. And here you can see that in the case of the Latino population, Latinos in the entire country are 1.9% more likely to report a COVID-19 case, 2.8% more likely to be hospitalized, and 2.3% more likely to experience death. And this is relatively similar to the case of the Black population in the entire country. So this brings us to the next part of my presentation, that is, well, why Latinos have been disproportionately affected by COVID-19. And based on the research that we have produced at LPPI, this can be attributed to different factors. And the first one is the overrepresentation of Latinos in frontline occupation, meaning that during the pandemic, it was very difficult for the average Latino population to work in professions that were able to work remotely. So more people were exposed to the virus given the nature of the work that Latinos perform during the pandemic. The second key factor is also the Latinos are more likely to live in overcrowded housing and to use public transport more often. So these are two risk factors, particularly at the beginning of the pandemic, when transmission was more common in households, and also during the commutes from work to their places of residence. So that also put Latinos at a higher exposure to getting infected from COVID-19. Also, the higher rates of hospitalizations and death are related to the higher prevalence of pre-existing medical conditions, such as diabetes, hypertension, and obesity among the Latino population. And this is also linked to social determinants of health, such as poverty, discrimination, and residential segregation that the literature in public health shows that are highly correlated with worse health status, worse access to healthcare, and in the case of the COVID-19 pandemic, increasing rates of contracting COVID and of experiencing complications. And also, one of the particular vulnerabilities that is reported among the Latino population is the lack of or inadequate health coverage. We know that the highest uninsurance rates in the state are among Latinos, and lacking health insurance makes access to and use of healthcare more complicated. So this was also one of the main factors that delayed care, or essentially people go to the hospitals when their cases were too advanced, mainly because they either lack insurance or any type of knowledge on how to navigate the healthcare system. And even though COVID-19 treatment was not built, it was open to everyone regardless of insurance status, the fact that many of these individuals were not socialized or were unable to know how to navigate the healthcare system deterred many individuals from doing that. And in the case of those Latinos whose immigration status made them to be fearful of accessing the healthcare system, also was one of these key explanations of why COVID-19 was disproportionately affected Latinos, mainly because undocumented immigrants who are of Latino fear that if they went to the doctor, they will encounter possible potential deportation, or they encounter some situation that would be related to their immigration status. If you recall, at that time, there was all this discussion about public charge that deterred and created chilling effects among many Latino immigrants in using public health services such as healthcare utilization. So for more information, here is the link where you can access the report that I'm just summarizing very briefly here from the Latino Policy and Politics Institute. And so what can we do about this now that we are moving out of the pandemic stage of COVID towards its endemic stage? So first of all, I think it's important that what we have learned from the pandemic has showed us that access to healthcare is very important among the Latino population and other people of color. So obviously the main recommendation would be to expand health insurance coverage. The current move for the state to expand Medicaid access to all, including the undocumented, by 2024 is a very positive step in that direction. Another silver lining from the pandemic that has helped us improve access to the healthcare system is the expansion of telehealth. So we just need to make sure that telehealth is available to Latinos and other people of color, and that they are able to access broadband and they are able to get the care that they need, particularly chronic care management, through telehealth at the same rates as other race and ethnic populations. And what we have learned from the pandemic has also shown us that in periods of crisis, when we create income and nutrition support programs, such as the stimulus checks, for example, should not exclude immigrants, because these impacts negatively those populations who can benefit from this income and nutrition support the most. While California did some policies to address the situation, in other states that where immigrants live, they were unable to benefit from state support in terms of income and nutrition support. Another potential policy solution that would have tremendous public health benefits is housing affordability. This is behind the crowded housing effect that we can see in the transmission of COVID. If we are able to provide housing at more affordable prices, then that will allow for more individuals to live independently and to avoid these situations of crowded housing. And right now, there's this controversy about whether to keep funding COVID-19 vaccination, testing, and treatment. The Congress has decided not to do that. There are still negotiations. So we need to advocate for this funding to remain in place, particularly since it benefits the most underserved populations, people of color, and in the case of California, Latinos. And I think that the more towards the medium term, as we have more perspective on what happened during the pandemic, as more research is produced, I think we need to prepare for the next pandemic and learning from this pandemic and using a health equity perspective in the preparation for the next pandemic or the next emergency situation where we need to coordinate to address unforeseen circumstances. So with this, I finish my presentation, and I will definitely love to continue chatting with you in questions and answers and hear more of what you have to say about this topic.
Muchas gracias, doctor. I'm going to try to see if I can get everyone to see themselves. Are we seeing the same thing? All of us kind of in the same view?
Yeah, it's back in gallery view.
Okay, perfect. That was a great presentation. Muchas gracias, Dr. Arturo. As you mentioned, the HRSA uninsured program, that definitely came to mind. Funding ended yesterday for people to get free COVID-19 testing and treatment. And actually, COVID-19 testing is going to be ending in April, early April. Can you say more about that, Doctor? What you know as far as who makes those decisions and how can we advocate to make Congress approve for more funding?
Yeah, I think it was part of a proposal to extend COVID funding as part of the Biden administration new policies to deal with the virus in this new stage where we are going to be becoming more familiar, to living with the virus in the transition towards its endemic stage. Unfortunately, the Republicans in Congress blocked this funding, and they decided to eliminate, at least temporarily, the funding of all these services. And this will obviously have a negative impact among people who are vulnerable and who rely on these free testing, free vaccinations, in order for us to continue finally getting out of the worst part of the pandemic and getting prepared to live in the new stage. So I think this is a very difficult stage where advocates are needed to regular representatives, to coordinate with different organizations who are part of this conversation for us to get the word known that there's a huge need for this funding to continue, not only for those who remain underserved, who have been the most affected by the pandemic, but also towards the future, to facilitate the transition into a better, more predictable coordination between the provision of health services and those people who need it the most.
Hey, can I ask a question or add something to the conversation here? My name is Jeanette Contreras, and I'm the Director of Health Policy at the National Consumers League. I'm currently engaged in a lot of the, submitting regulatory comments to the Centers for Medicare, Medicaid, and Medicaid Services so that, we ensure that, the regulatory side, the flexibilities are maintained. All these public health emergency flexibilities that were put in place, we don't want them to see, we don't want to see them go away. There's an opportunity right now that CMS is calling for comments, and they're due April 25th. So it's like a short window. But that's one opportunity where I would suggest that the coalition submit its set of comments. They're actually interested in looking for, what are some things that they can do to improve health equity. I'm happy to share it with the group in the chat, and would really welcome, collaboration on this. The National Consumers League, in my role, we are submitting our own letter. I am also interested in potentially doing a sign-on letter. So I don't know if that would be helpful. We could have all of the organizations join a sign-on letter, or we could even just throw the LCAC, letterhead and have everybody join. But would love to work on collaboration on this. Dr. Vargas Bustamante, your presentation was spot on. Your policy recommendations are spot on. I love the way you tied really like the problems to the solutions, and what I was furiously writing down and taking screenshots of things was how you clearly connected everything, the social determinants of health, to it. I'd love to talk offline about how to do more of that kind of focused work. For example, I want to engage with housing advocates, right? I think we should be doing public health in the housing projects, right? I mean, that's really, a needed thing. When I was doing ACA rollout, 5-6 years ago, I was at CMS, and we had the policy of there's no wrong door to enroll, right? No wrong door to access. We were enrolling people at food banks. We were, doing like now one of the flexibilities I was writing in our letter to CMS is reviewing eligibility based on SNAP eligibility, right? If you're eligible for SNAP, you should be eligible for Medicaid, right? All of these sort of like auto renewal things that make it, I guess, more difficult for states to drop people from their roles, right? I do national work. I'd love to, I know that a lot of this was focused on California, and we have an issue that I always think about when I look at your data, and I wrote down here. Would love to hear your perspective on this. The Asian American rate of vaccination was really high, and their population has a lot of similarities in terms of immigrant population, right? So the chill effect of the public charge that we were talking about, limiting English proficiency, right? Something that, so what is it that they're doing? That they're vaccinating more people than the Latino community? That's something that I think about, right?
Yeah, I think that there are two explanations, and the first one is first is access, like lower health insurance coverage, and less knowledge on how to use health services makes it more difficult, even if those services are for free and available to everyone. It's makes it more difficult for individuals who don't know how to access or use any services, given their condition of uninsured individuals. To feel like they deserve to get a vaccine, or that they can do some testing, because they will always fear that is there going to be a cost associated with this? Is there going to be some type of immigration consequence if I do get this service? And then the second explanation is also something that has played a role in the non-Latino white population, that is the misinformation. There has been like all this type of misinformation campaigns, not only in English, but also in Spanish. And I don't think that, I think that misinformation and all these campaigns have negatively impact a lot of Latinos who are subject to this type of narratives from their social networks and from their peers. So I think that both the issue of lack of access and the misinformation has negatively impacted the vaccination rates among Latinos.
Yeah, it's just hard to make the case of lack of access because, you know, like we think of Asian Americans as the model minority, but that's really a myth, right?
Oh yeah, of course. Yeah.
You know, so I feel like they have similar barriers to access that Latino community does, you know. So I don't know, I'm from Los Angeles, so I sort of understand, you know, growing up in immigrant communities and stuff, but it's just interesting that, you know, they just did such a better job of vaccinating their communities. And what you mentioned, misinformation, that might have been it. That might have been the linchpin. That might have been that like extra thing that was not a barrier to them in their communities, right?
Right.
Be it for
because
whatever.
if you see like immigrant populations are similar, like distributed is not that difficult, not that different. But I also think that there's a difference in terms of education, years of education between Latinos and Asians. So perhaps on average, Asians have more years of education compared to Latino population. So perhaps that difference in the number of additional years of education could have played a role in being able to like discern versus like lies from truth about the vaccine, and also to do more research into like legitimate sources of COVID-19 information. So that could have made it more acceptable for this population to get a vaccine. However, this is totally speculative. I have not seen anything published about this, and I'm sure that many researchers are going to be doing this type of research to try to find what the main factors that explain these differences.
Yeah, and the last thing I wanted to break out, because it's sort of related, is how what you were showing in terms of actual numbers of vaccination rates, those are, I mean, the cases, actual cases reported and deaths reported, those are really underestimated, right? That's just sort of like scratching the surface of what the reality of the impact was because of underreporting in this
underreporting and the excess deaths. Like there could be a lot of people who died from COVID-related causes, and the death was not like recorded as a COVID.
Yeah, so the CDC posts their case numbers, and they always put there that they estimate. They say this is the number based on estimates. So they go above what was reported to create their estimates, what they report. So just that.
Thank you for the great comments.
And Jeanette, just to let you know, I put my email on the chat. So if you want, we can collaborate. We can, definitely do something together. And don't forget, if you want to raise your hand to ask a question, feel free to do so.
I think Claudia had a question prior. I'm just going to read it. I think it's mostly misinformation, and even when doctors confront them, I'm guessing she means patients, they don't always agree with the vaccine. Which community was successful?
Yeah, sorry. Yeah, I guess I was trying to just contribute to the conversation, and also share some frustrations up until the day of today, to be honest with you. I didn't hear that it was the Asian community. I hadn't. I guess I missed that portion. So yeah, we'll just continue the conversation. Sorry, I wrote that when Jeanette was talking about it's not just lack of access, and it's true. and you pointed out very well, Arturo, it's also education. I think it has to do with that.
And at the end of the day, it's going to be very kind of difficult to tease out what is going to be the individual factors, because education is correlated with other social determinants of health, like segregation, income. So like identifying what is like the key factor that explains these differences in uptake is going to be, I think, a good amount of research is going to be produced, debating how would it be better to measure and estimate what was like the main explanation behind this difference. So I want to like to continue the conversation. I perhaps want to propose a follow-up conversation topic, and is how do you think it would be good for us to get organized in order for the next pandemic to have a health equity lens when they do the planning, when we in California, Washington, D.C., when we prepare for the next pandemic? What do we need to do in order for decision makers to take into account the fact that this pandemic hit people of color the most, particularly Latinos, Black population, Pacific Islanders, Native Hawaiians? So how we can bring this awareness to these decision makers in order for them to take this into consideration when the next time that they prepare to do to react to, because it's going to happen. That's a fact from life. No? Or even the COVID-19 pandemic, we could have a surge with a more like a lethal variant, not too far in the future. So how we can bring this to the top of the policy agenda when decision makers sit in the table to prepare for the next pandemic? That's something that I recommend, but I honestly have no idea how to do, but I would like to have that conversation with you guys.
Well, I don't want to monopolize, but I feel like I can engage with you. I'm having an opportunity to speak to you. I'm going to take it. So you mentioned telehealth in your talk, right? And I think that's really important that we, ensure that telehealth is made accessible, right? We talk about the digital divide, and everybody was getting care from home, but not everybody can do a video visit with their doctor. Right. So we need to have those authorities in place so that the physicians could get reimbursed for telephone visits, right? The telephone interaction. And what do we, how do we prep the community for that? One, we can ensure that, that's regulation is put into place, or there's maybe a telehealth bill, pass something that I'm not really too familiar with, but then, is this something that the community will really respond to, right? My mom had to do a telephone visit with her doctor, and for the first time, and there was a learning curve there. And she was like, well, okay, this worked. I said, how did you like it afterwards? And she's 78. So
yeah, there's like a huge advantage of because access to healthcare is a big issue even before the pandemic, and telehealth improves access. So if we can make it like an effective tool for those who experience the most difficulties accessing healthcare, it could be a very effective way of taking advantage of what we learned during the pandemic to improve access to healthcare after the pandemic.
If I could add something, this is Russ Bennett.
Yes.
To both what you're saying, Doctor, and what Jeanette is saying, how do we, if we can allow people to use telehealth or to use telephone health and reimburse properly to the providers, then I think we need to educate our community about telehealth. And maybe we need some brief videos, advertisements, or on social media where a person actually goes through a consult with a physician on the phone. And to Jeanette's point about her older aged mom who was comfortable with the visit, to be able to show people doing these visits, being comfortable with them, and saying, wow, I didn't have to get on the bus or drive for a relatively long time and sit in the waiting room. and I was able to get my doctor's input, very quickly. I think if we educate, we can, market through education.
Yeah, and at the end of the day, I think it's also going to be a lot of the word of mouth for those individuals who had like a positive experience with telehealth, particularly those who are the more reluctant. But for that to happen, you definitely need to have like very good like broadband, smartphone. You need to have like basics, and making sure that individuals who would use it have those basics would be definitely key. At the end of the day, telehealth also includes phones, and that the reimbursement rate should be the same or equivalent based on the level of effort for both the phone and the video options. But at the end of the day, I think it's going to be like the future of at least primary care. It will have to become more accessible, more convenient, because the way we have been delivering healthcare, it needs updating. And it's not working for millions of individuals who cannot afford to leave their jobs and spend an entire morning with your primary care provider who can only provide an appointment in 3 months from today. So I think that telehealth brings a lot of advantages that we need to take to think how to upscale it and make it accessible to individuals who are right now not benefiting as much as they could from it. So what else?
So I just wanted to give a plug and put in 2 links. We actually do have a digital compañero program that we're trying to expand to try to bring digital literacy to the community. And of course, the next step would actually have the physical hardware to do that with. As an educator myself, is something that I'm trying to develop with Daniel and others in the coalition, is to address this necessity to have, as everything gets digitized, to have this connection to information, so that misinformation gets dealt with, but also accessibility to health, healthcare, and other bridging the gaps of other health disparities, not just vaccinations. But that has to do with the fact that a lot of it also has to be taught. So we're trying to put together sort of the educational aspect of that, so we can have like either other educators or physicians themselves, public health personnel, to kind of help build together some sort of curriculum to allow for the community to be sorry, I'm trying to navigate things here, to try to be literate in a lot of the higher level tech that they have, because most people know how to navigate social media. Most people have some sort of either cell phone or hardware around them. It's kind of to bridge the gap between what people need to access this information and actually know what information to access that is valuable. So I put a link for that. And also some of the stuff that we had been mentioning before. We do have a call to action that we are signing as a petition to demand that we do have legislation, and we have local, state, and federal awareness of the issues that have faced our population in the past. And that link is also here for us to sign and to review. It's still under process, but it's about to be done and published. So if you guys want to also click on the link and actually take a look at it, it's there. Thank you.
I'll also mention, so as a sort of a researcher in the county hospital, one thing that I think would be crucial and imperative for our Latino families, especially monolingual Spanish speakers who come into the hospital, community health workers have been an underutilized resource that has been needing some, real legislative policy implementation at the California level. There are other states who have already started to reimburse for community health workers at the state level. But I think, that's one thing policy-wide that as a state we could push for, to have more integration of community health workers in these spaces. And that could also, improve some of that speculation that sometimes families have with regards to discussing certain things with their providers. I know there were other comments in the chat. I think Beatriz and others, if you have something to add, please feel free to. Genoveva. Oh yeah, Doctora Zorina, go ahead.
Hi, everyone. So I think that also some sort of clearinghouse or something where Spanish-speaking providers can be identified, because I know during the pandemic, people, the Latino community was seeking providers, and it was just very difficult to connect people. The lines were all tied up. You leave messages for providers. They never return the calls. I mean, I know that was a more urgent time, but I still think that we just don't know where and what institutions there are Latino providers who would be willing to do this telemedicine. And, you know, that's another area that research could be done in. Where are they? Do they want to be available to the community? How can we access them? You know, do we need navigators to connect community members with them? There's just so many unknowns. You know, we can say telehealth, which is a great idea, but I think there's a lot of work that needs to be done to set up telehealth as a viable vehicle for the community.
I totally agree with that comment, because we don't, as you probably know, we have been experiencing a shortage of providers, particularly in certain actual shortage areas, as they are acknowledged by HRSA. And telehealth has this great potential of making those who live in these shortage areas to get the care from the providers where they are available. But if they are not available to work through telehealth, then how this is gonna work? And I think that at the end of the day, it's gonna be whether the reimbursement is similar to that of working in person, and whether there's like the incentives in the table and the regulatory changes in place for this to happen. For example, by allowing providers from other states to participate in the market. But this is the conversation that will have to happen at the state level on whether we are more flexible at allowing Latinos who, let's say, live in other states to serve patients who live in California. Telehealth could make that possible, but so far, there are licensing issues in place that may not allow that to happen. If that's not possible, then it's going to be more difficult for those who could benefit from it to get access to telehealth services in Spanish or in other languages, where you can also find scarcity of providers who provide services in Tagalog and other languages where we don't have that many physicians and other healthcare workers who have those skills. And in the case of the community healthcare workers, I think that could be also a way of trying to mediate the message about the effectiveness of vaccines and how useful they are at preventing the consequences. And those individuals who are still a little hesitant, particularly if they are hesitant related to issues of misinformation or lack of understanding of why it's important to get the vaccine. Community healthcare workers will potentially be an appropriate channel to transmit that message to this population.
Yeah, I was just going to add one more thing. I think that from my understanding, community health workers are often contracted by hospitals to keep readmission rates down, because it helps with their quality rating, and when they're coordinating transition of care, right, or people that do outpatient to try to keep them from getting, re-hospitalized or readmitted, right? So yeah, there are definitely ways that, reimbursements can help to either pay for the community health worker role as, a patient navigator to help people with outpatient, procedures to help make sure. But yeah, we're not there yet. And only large hospital systems are able to do it, right? Because they have the funding and then the incentive to not get dinged for readmissions.
Adelante, Genoveva.
Hi, I'm Genoveva Islas, and I am in Fresno. I did want to chime in on sort of this point about needing to work to sustain our promotores, because absolutely, I think in COVID, you know, they have just played such a tremendous role in engaging our community and helping to support them in accessing resources. We definitely need a model that sustains them outside of hospitals, outside of the medical system, because there is jeopardy in thinking about just tying them solely to reimbursements from the healthcare industry. Here in Fresno, we're contemplating a model, and it is connected, but that reimbursement would only come if the promotora were to be successful in, say, connecting a resource, right? And if that connection, if that pathway isn't completed, their hours spent with that family do not get reimbursed, right? And so in low resource neighborhoods, this becomes the jeopardy, right, of creating a model that's solely about the completion of referrals and pathways like that. So I would just say that, you know, there are numerous efforts, the Health Equity and Racial Justice Fund, other efforts that are trying to establish funding streams at the statewide level that hopefully would get to nonprofit organizations to sustain that work. And the truth is, like, this is a way where we're going to create living wages and employment opportunities for the most vulnerable, who are exactly the people we need to have employed to reach the vulnerable Latino communities that we're hoping to serve, right? They have the cultural context, the lived experience, right? Like all of those things that we really want to position them to do. So I just wanted to give that caution, and I think another sort of area for advocacy in terms of having some sustainable funding to support them. Otherwise, sort of this tremendous infrastructure we've created in response to COVID is going to dismantle, right? And it's going to be such a tremendous loss for a lot of places where there has been success.
Thank you for your thoughts. We have time for one more, Dr. Munoz. Adelante. Dr. Munoz, you're muted. Okay, there we go.
Perdón. ¿Sí me escucha? Sí, ok. Yo tengo las dos experiencias cuando vivía en California y ahora practico aquí en Tampa, Florida. Durante la pandemia, la telehealth, I'm sorry, I don't speak Spanish. I had experience in both states, in California and Florida. My experience in California was mostly fee-for-service, Medicare, Medicaid, and private insurances. Here in Florida, most of the patients are managed care. So that, for me, has been a big difference. And all the challenges that you are facing over there, they practically doesn't exist here. The insurance were allowing to do a telehealth just with a simple audio call, right? Everybody has a phone. We have the number. We call it for audio, what's it called? Video call. And that was very simple, very simple. Because it's a managed care insurance, the physicians and the organizations are very what's called into looking for the health of the patient, because there's a different approach. Here we do a lot of preventive medicine. So we look the patients, we call it every single time, trying to do something that you may heard, that is the annual physical exam. So we gotta do it. So in reality, the only challenge that we had was those type of visits has to be in person. All the other consultations can be done by phone. And because it's a managed care, it's an HMO, we don't get reimbursed for that call. but we keep the patients out of the hospital, which is what we are trying to look, right? We're trying to prevent complications of the chronic conditions, and we address the acute problems. So my experience is that California has to move faster to the managed care. Here, to see a patient of Medicare is so rare. We never see them. I left California about 6 years ago. I don't know if that has changed, but my previous experience is that, and it makes a big, big difference. The patients get all the attention. We see it 3, 4 times, 5 times a year, and they are well kept. We do all the preventive medicine. I don't know if that's changed in the last 6 years, but I think that's a model of Medicare that is working in this area, and we are pleased doing that. So I just want to share that with you guys.
Thank you. Gracias, Dr. Muñoz. Any final thoughts? I know we're a little bit past the time already. It's 6:31, and I want to be respectful of people's time. I did add Daniel's on standby. He can't speak right now, but he's so appreciative to you, Dr. Vargas Bustamante, and has just been over the moon with all the comments. So we're really excited. I just put in the chat the COVID vaccine education and empowerment detention center detention program, which is to have volunteer physicians to speak to ICE detainees. I don't know if you all saw that wonderful article that came out on NPR and Kaiser Health News and other sources about the program. So we're still looking for volunteers for that. So if you know somebody, please feel free to sign up or send it to your contacts. Any last minute thoughts before we wrap up? Sounds like we definitely have to follow up with you, Dr. Arturo, about having you come back. There was so much excitement and activity around this topic. So we definitely welcome any last minute thoughts.
Sure. Well, I think it's a great conversation how we started today here. I think it's important for all of us to keep tracking the policy developments in the case of the COVID-19 funding that is still pending, and do as much as we can to keep that funding stream in place. Otherwise, it's going to lead to even worse health inequities or healthcare inequities. So I would just finish with that, and I really enjoy meeting you all, and hope that I can interact with you again in another occasion. Thank you for the invitation, and please say hi to Danielle.
Muchas gracias.
Gracias.
Ahí nos vemos y que estén muy bien todos. Muchas gracias. Chao.
Bye, everyone.
Thank you. Bye.